in the last year, I've seen more adoption and transformation and subscription to everything that you're writing in that book. I mean, exponentially more adoption than I had in the last 10 years. Welcome to the Alfi Podcast, episode number 22. This one I've been looking forward to for a very long time. Very excited to have Dr. Sandra Kahn in our studio. Thank you for coming.
My pleasure.
For those of you who don't know, Sandra Kahn is an orthodontist, a pioneer in the airway space. She wrote one of my favorite books, which you can see on the table, called Jaws, which really explores the airway health hidden epidemic and has a lot of pearls about what we need to do to fix this. And my favorite chapter actually is the last chapter in the book about what we need to do to make this message mainstream, which is something I talk about all the time and a mission of this podcast and our practice. What's very cool is that book was written or published in 2018, which means that this information, which is still new for a lot of people, still not in the curriculum here in the United States in most dental schools, medical schools, is not part of mainstream medical education or practice. But you so eloquently articulated and demonstrated its importance and pearls in a book you probably started writing years before then. What was your moment that started this really alternative pathway for medicine that, you know, I'm sure being in this space now and getting all the criticism from people that learn the traditional medicine and see this as something that's alternative. I can't imagine what it was like, 5 years ago or 10 years ago. But for you to put it out in such a powerful way, how did you get there?
Well, I think a lot of disruptors like me start with their children.
Yeah.
And I had a son, and he was a mouth breather, and his mouth was always open. Luckily for me, he had no malocclusion. His baby teeth were all lined up, not a lot of spaces, but he really didn't have a class 2 or a class 3 that we could look into. So I explored and I tortured him, and he was my guinea pig to everything I could find.
When did you notice the mouth breathing issue?
Well, I knew for a long time, being a dentist, we know that when your mouth is open, you're going to have more decay,
right,
more gum disease, bad breath. I mean, we know the open mouth patient as soon as they come into our office. When I was a general dentist, you could see that patient just sitting, reading with their mouth open, and you knew exactly that you're going to have tartar and gum disease, and you were not going to get out of that. So this is something every dentist knows.
Yeah.
But if you don't have a hammer, you don't see the nails.
Right.
So we didn't have a way to change this effectively without driving the patients crazy.
Yeah.
So we didn't even talk about it. And we mentioned it to the patient, but he was like, okay, you need to floss more. Next.
Right.
So it really starts right there.
Yeah, but this was not something that you learned in your curriculum, or was this stuff that was taught in dental schools or in your training?
No, not at all. Not at all. I went to dental school at the UNAM in Mexico. And we did my best friend's a surgeon, so we were doing a lot of surgery and just hanging out with the big surgeons. My first love was cleft lip and palate. We had a lot in Mexico, and we had these trips up in the hills so that we could do the programs with the highly deformed kids. And you could do anything you wanted there because the parents would be open to everything.
Yeah.
We would take little babies and take alginate impressions, and they would cry, and we would just tell the mom, "Oh, just hold them; they'll cry."
Right.
And parents back then, and in those areas, they would let you do whatever you needed. And I knew that these cleft lip kids, they could breathe better if we improved the nose. So we were always trying to figure out to give them decongestants and to kind of teach them. And these kids, as they grew, they knew that they were not like the other kids.
Right.
So they were willing to do whatever we asked. we started with myofunctional exercises, and I realized that really didn't help very many of my patients. So we just kept thinking of new things. In JAWS, I did write about putting tape over the mouth, which I frown upon these days.
Yeah.
And we just have to move on because it's so new and there's so much information.
Right.
And you got to move to the next thing when something doesn't work.
Right.
But science is a little slow moving because you have to prove everything. And by the time you're ready to prove it, it's not going to work.
Correct.
Because something that we used to rely on that we don't rely on so much is the empirical process. So you treated. I have 7,000 patients in my database.
Right.
So I've treated a lot of kids, a lot of patients, a lot of different hospitals, and I could see the things that were worth looking into deeper, and the things that didn't.
Yeah.
And the tape seemed like a great idea because you want to close the mouth. But then I discovered Dr. Engelke. I don't know if you're familiar with him.
I'm not.
But he's a triple PhD. He's an ENT, maxillofacial surgeon, and phonoaudiologist. So he had the 3 PhDs. And I read his articles, and I said, we need to find this guy. And he was already retired, and I flew around the world to find him. And he was already moved to other things, but he was the guy that taught me about the valves.
Yes.
And the mouth, the lips are a valve. They're not lips when you think about moving a fluid from the outside world into your inside. So he taught me about the 7 valves of the mouth, of the oropharyngeal complex. And I flew to Germany at Göttingen, spent 3 years writing a book with him and figuring out how to get these valves to work properly so that the mouth could actually be closed without needing something artificial.
Right.
So we have it in ourselves to create a little vacuum to hold our mouth closed. But everything, the architecture has to be in the right place.
Correct.
And that's your job.
Yes. Yeah. For my job, for those who have failed intercepting it earlier in life, but let's talk about that. What happened? Because we talked briefly. I know you're interested in anthropology. We weren't created, designed, evolved, whatever anyone believes in. We weren't designed to have crowded teeth, to have no room for our wisdom teeth. What happened? And it seems to me that it's happening at an accelerated rate, not only over the last 500 years, but in the last 10 years that I've been seeing patients.
Well, I've been recently diagnosed as a neurodivergent brain. So I used to think I was ADD, HD, whatever. Now I have a new diagnosis, so I love it because it gives me permission to be crazy and go to the next thing and forget the old one. So I'm writing my 7th book now on the nose, and I totally forget the other ones. The nose is quite a forgotten organ.
Yeah.
You can find in every household somebody says, oh, my nose doesn't work. And looking at anthropology and working with Dr. Ehrlich, he's 92 and as sharp as you and me.
Is he a nose breather?
Nose breather. Long face, though.
Yeah.
But definitely nose breather. And he grew up in, I think he was born in 1931 or something. I'm not good at math. But he was born in a different atmosphere. So the air was different when he was born in 1931.
Yeah.
And it's really interesting to see that the nose now is dealing with very new stuff that wasn't there 10 or 20 years ago. We have new particles, and children just have stuffy noses. They just have stuffy noses.
Yeah, right.
Yes, chewing is important. Our muscles are important. But what is it that's going on today that wasn't there 50 years ago when nobody needed wisdom teeth taken out?
Right.
And we were actually eating very soft foods. And there are communities in India where they eat very, very soft foods. They have bacteria or whatever, so they have to overcook everything. They can't eat anything raw. And they have good development of their jaw.
Yeah.
So then I went into thinking, okay, it is the consistency of the food, but it's also the amount of the food.
Yes.
Because when you have too much food, you take the next bite over and so quickly. You don't take the time to rest.
Savor it.
Yeah, and just rest. In our GoBix program, we work on the pause. So you want to take a bite, chew it well, and then rest.
Yeah.
But even if the food is hard, if you're taking the next bite, you're not resting. And growth happens when we're resting, right? It happens at night. We have their hormones that are secreted at night. So we have to train our brain during the day to have that rest. So that was my theory.
Yeah.
Now, when I've been looking at the nose, yes, we're not resting, but why aren't we resting? Because our noses are overwhelmed. It's not that we have allergies. It's not that we have, microplastics, or there's a lot of new things. And our nose just has to slow things down in order for us to recognize, manage, and process what goes in our lungs.
Yeah.
And the process, I don't have to tell you this, you probably know it better than me, but the nose will clean, moisturize, condition, regulate the temperature, add nitric oxide. So we have this magical stuff going on in the nose.
It's made for breathing.
At night, when we rest and repair and digest, we want exclusive. And our ENT that we're writing with, Dr. Rangel, who I want you to bring up and interview, because I don't think anybody knows more about development than this guy. Yeah. He's amazing. But he says basically that we need to have 95% effortless nose breathing at night.
Yeah.
We have to get the surgeons in.
Yes.
Because you guys need to do a better job.
Yeah.
And it sounds that like you're doing a good job.
Thank you.
Which is great, because I've had bimaxillary advancement. Not because I needed it.
Yep.
But when you see something, you can't unsee it.
And I talk about bimaxillary surgery as the ultimate biohack. I'm very interested in biohacking. I think this alternative medicine and focusing on health and wellness is very interesting. Having gone through dental school, medical school, I feel that traditional training is really taking the focus off what the body can do for itself and made us dependent on so many other things. But our body is magnificent. It really is magnificent. It's a miracle worker, but we have to set it up for success. So biohacking, I think, taps into that. And there's nothing more powerful than opening up the airways, being able to breathe through your nose better, having room for your tongue. So I believe you when you say you weren't a traditional patient that needed jaw surgery, but being in this space, understanding breathing and how important it is, and sleep, how important it is at the level that you do, it makes all the sense in the world that you would pursue it. And now you're proving that it's the ultimate biohack. I'm not going to say your age, but you're doing much better than all your peers.
I mean, it's just amazing how my life has changed from having had the procedure. It's been, less than a decade. But just being able to have that deep sleep, you don't know until you have it, that you didn't have it.
I hear that from patients all the time. The time. Because, you never know you think you know what it's like to breathe because that's all you have. But then when the passages are open and it's effortless, it sounds like it's a whole new world.
Yeah, we are talking about a new term, which is nose expansion. Yeah. And it really makes sense because when we're dealing with this new, we call it the novel atmosphere. And there's so much new stuff that we need to process in our nose. Yeah. We need bigger rooms. Yes. We need a bigger house for the furniture. Right. So the turbinates are the furniture. Yeah. And if we expand the jaw, we're making that pyramid, the floor of that pyramid. And we forget that it's the same real estate. Right? First floor is the mouth. Second floor is the nose. And we share that floor and roof. Yep. Exactly same structure. So if we make the base bigger, we are expanding the nose. Absolutely. People look at me like crazy when I said, we need to do some nasal expansion. And they're like, what is this? Right. It's traditional, regular maxillary expansion, orthodontic.
Yeah, that's the way I've been thinking about it. And at some point over the last several years, I really started paying attention to that when I do the Lefort osteotomy. And I'll remove bone from the crest of the maxilla. There's always redundant, excessive bone. It almost resembles a torus. And I'm really curious to see if that crest is larger now compared to ancient skulls. I think the answer is going to be yes, but there's a lot of bone and taking up space where the turbinates are, and the piriform apertures are so small. The bony cavities of the noses now, especially on my orthognathic patients, are so small that when I'm seeing it live, it's obvious that that entryway by itself is such a big problem. So I'll remove excessive bone. I'll widen the floor of the nose tremendously directly as part of the operation and widen the piriform rims. And since I've been doing that, patients say that their airflow is night and day, tremendous. Even ones that have gone through MARPI and had expanders and then did this, they said this was a lot more nasal airflow. So it does make me think about that nasal volume, just similarly to what you're saying. And I think about, the popular treatment for all these patients with ENTs is to remove their turbinates.
No, not remove, please.
Remove or reduce.
Reduce. Right? Reduce is way better because I have patients
but I think both of them
removed.
I think that both of them are unnecessary.
Look, I'm a big proponent, and I do want to get back to your biohacking because we talk about reverse engineering your health, and I think that's what our responsibility is now, especially in the medical environment that we're living all over the world. But I will talk about that later. But I do want to say that I'm a big proponent of transdisciplinary work, which is different than multidisciplinary or interdisciplinary, where you work with other specialties. Transdiscipline, it's really going into the other discipline and finding out exactly what they do. Like, I'm going to go to the OR with you tomorrow. I'm so excited.
I'm excited for that.
And I want to see what you're doing so that when I refer it, I know exactly what they're going in.
Right.
And my peers, the orthodontist, the pediatric dentist, they say, well, we sent to the pediatrician, we sent to the ENT, and they say, oh, everything's fine. And then I take a little camera and I put it 0.5 centimeter inside the nostril. And in the screen, I show the mom and the kid that the turbinate is taking all the room. Yeah. And there's no room for the air to go in. So how are they going to tell their kid to chew with the mouth closed?
Right, they can't breathe.
So if you see that and you understand what is it that the ENT can do, and if you invite Dr. Rangel, I mean, he's so close to Houston. It's like next door.
Michelle will have to invite him as a guest.
But when you see what he does, yes, the patient has to be put under.
Yeah.
But what he does is he burns the submucosa, not the mucosa, because that's where the magic happens.
Right.
The mucosa is where the nitric oxide is and filtering, and the cilia that are cleaning, and the water's secreted to get the moisture right and the temperature. So everything's happening in the mucosa. So he uses radio frequency to go through the mucosa and reduce the size.
Yeah.
I would never say remove a turbinate. It just hurts because I've seen patients that have empty nose syndrome.
I've seen it too.
So you want to be...
it's a real thing.
Yeah. You want to be a disruptor.
Yep.
And you want to get things, but you want to see who's doing it. He's been doing it for 40 or 50 years because he's in his 70s. And he's got the technique down.
Yeah.
And he prioritized the air going through the nose. So if we are going to do everything together, you can give me a huge palate, a huge mouth. You can move it forward and open that airway. We can work with myofunctional therapists or what we call biofunctional therapies, which work on that suction. We call that the up-lock. And I brought you some toys for you to test it in your mouth. And they can show the patients what to do with the real estate.
Yes.
So when a patient goes in and has the right nose procedure, minimally invasive surgery, minimally invasive turbinate reduction.
Right.
There's no inflammation. It's
structure.
distension.
Right.
I've been schooled into the right terms. There's no inflammation in the nose. The nose is just dealing with a lot of new stuff, so it has to slow down. It has to create turbulence. We create that turbulence, And if we reduce the size, then the air can flow more efficiently. So I know what you're doing. You're giving me the real estate.
Yes.
I can teach the kids or the patients what to do with that real
Yes.
estate. And if they need nose work, you can do it, or we can have a minimally invasive procedure to get that nose optimally working.
Preserve the important turbinates. Let's talk about breastfeeding.
Okay.
How does that play a part for nasal breathing development?
Okay, so breastfeeding has been around over 300,000 years.
Yes.
Modern man has been here, but even before that, we were
Right.
breastfeeding, right? It is critical for a baby to create that suction. And just now, I'm living in Colombia, and we're doing a lot of testing with our nasometer.
Yeah.
I built a little device to check how much pressure. It's not real resistance; it's pressure.
Yeah. Okay, walk me through that. How does that work? How are you testing that?
So basically, you just close one side, and then you have a little manometer on that side. It doesn't go in the nose; it just obturates it, and then the patient takes air through the other side, and then you measure how much pressure there's in the we call it the epipharyngeal space, nasopharyngeal, epipharyngeal, different names. But you just see, and that tells you how hard the pumping of the lungs is.
Yeah.
So sometimes we do a polygraphy where we put in a band, and we see how much that is moving. So what you want to know is how hard the nose or the body has to work to get the air to flow through the nose. And interesting, we want to measure children when they're asleep or even adults, because we want to know how they're breathing when they're horizontal, because we have different functions at night. And we have found, again, empirically, because the science is not out yet, but we've seen that when a baby is breastfeeding, it's creating suction so hard that the nose clears up. And I'm working with mostly sick babies right now. I have a baby that has malformation of the larynx. I have another one that had a teratoma that was removed, so he has his feeding tube. So I'm doing a lot of testing with babies that are in the hospital. But this one baby that had the larynx problem, he has a hard time breathing because babies are necessarily nose breathers. They can't breathe through the mouth. And these babies, they need to suck. So they want to be at the breast the whole time, because when they're breastfeeding, we measure their nose, and their nose is doing fine. And you can see the baby's working hard, the valves are closed, they're sucking, and they're clearing their airway. So the soft palate, all the tissues are away from the airways. So breastfeeding has a lot of functions. Obviously, we know about the milk, the breast milk, and all the immunity benefits.
But the work.
But the work is important, but also I really hadn't paid attention until we started measuring, is that when a baby is breastfeeding, the nose is absolutely clear. I would say 95% effortless breathing when breastfeeding. So the non-nutritive sucking is important. So it's not just about the milk.
Right.
And obviously, I breastfed my daughter till she was 3. So you don't want to have your baby at the breast all day long. But my son, who was the mouth breather for my kids, he wanted to be breastfeeding all day, even when he had enough milk. So why is that? Most likely because that helps them clear the nose. Yeah. So breastfeeding is great. Yeah. I mean, I don't know what else you want me to say about breastfeeding, but I think we know.
No, that's what I want to discuss, and its mechanism of action for development of the jaws and its.
Well, when we're breastfeeding, and there's very good ultrasounds of babies breastfeeding, so we know, and the lactation consultants and neonatologists, they know that we don't suck by squeezing and sucking. How we breastfeed is we slide our tongue to close a compartment, and then the compartment gets the pressure gets low until one of the seals breaks, and the milk gets accelerated all the way to the esophagus, which is quite far. Yeah. And when we look at the ultrasound, it's pretty clear that the tongue and the lips are not squeezing; they're just sliding to open and close the compartment. Yeah. And it's very critical for growth to have those those processes. Obviously, when you do surgery, and you were talking about seeing very thick bone in toruses, we see everywhere those very high vaults.
Yeah.
And the bone is going to go somewhere. We can't stop growth, as you know, from those class 3s.
Right.
We used to, back in the 80s, we used to put all kinds of chin cups and everything. You can't
Right.
stop the growth.
Right.
You can only redirect it. So if the bone's not going to go down and sideways,
Gonna go into
it's
the
going to
nose.
bunch up, and you're going to see it in the nose and in that high palate.
Yeah.
This is why you're having to remove that.
Right.
You know, like you said, you have to biohack people and give them
Correct.
what they should have had
Exactly.
when they were developing, but we didn't have the right breathing, the right chewing, the right diet, the
Right.
you know, exercise, living outdoors, the sun, vitamin D. I mean, there's so
Yeah.
many factors
Absolutely.
why our jaws didn't grow that we just have to tackle one by one.
Exactly. What are the biggest mistakes, if you can say maybe a couple of them, 2 or 3, that parents are making?
Biggest mistakes. I wouldn't call them mistakes because we are a highly social animal, and I'm an anthropologist, so I understand that as a society, we have even the mirror neurons. We are going to see what's around us, and parents are going to do what other parents do.
Correct.
And I wouldn't call them mistakes, but I would say we definitely need to to slow down kids.
Yeah.
We have to slow down the process. We have to pay attention to sleep. And we have to make sure that the rest is optimal. And I'm very happy, you know, doing things that some of my pediatric dentists hate. I'm working with a fantastic pediatric dentist. If you want to have her in the show, if you're interested in that, she has basically like a learning academy of, she calls it neurotrainers, and talks about neurology and pediatrics. And she's amazing. And one of the things they don't like are the screens, right? They don't want kids on the tablets and on the phone when they're little. I'm not against that because I think we're not going to be able to get rid of those. But I'm more for using them in a different way. So in our program, we show them how to use them to promote better rest. So you can have good posture, sit in the right chair, make sure the head is kept properly, that the mouth is closed, that we're keeping that suction inside the mouth, and we're prioritizing that nose breathing during certain very, very specific, meaningful training periods during the day. So when we go and we sleep, we are resting properly. So we have to learn how to rest. And I don't think parents understand anything about how their kids are resting.
Yeah.
So this is, I wouldn't call it a mistake, but I would say if I was able to talk to parents, I would say make a point of making sure your kids rest properly. And for rest properly, we use that sentence, 95% effortless breathing at night.
Right.
Forget about what they're doing today. Let them play, take them outdoors. Obviously, we have to work with pediatricians and make sure that they're getting that vitamin D and that movement and that proper diet and you know, chewing properly. But we need to train better orthodontists at going early and get this rest in the right place. Because if we have our tongue resting for 4 to 8 hours at night on the palate, the bone is going to respond to those slow or mild, light, sustained forces of that tongue being sucked up to the palate with very, very light pressure. And we have some manometers that we give even to the parents to measure their kids, to make sure they're staying within that very light pressure. Chewing is hard pressures. They're needed, but they're complementary to those constant light forces at night.
Yeah. Let's talk about pacifiers.
Love of my life.
I knew you were going to want to talk about it. Tell me about traditional pacifiers, and then you know, I want to get into alternatives. You know, problems with traditional pacifiers, if there are any. What are the solutions for that? And then to that same point, you know, a lot of mothers, for various reasons, or parents can't breastfeed and are dependent on using bottle. What is the issues with bottle, and is there a solution around that?
Well, I just wrote a paper on non-nutritive sucking reflex. And we do need to suck, and we have that reflex as human beings.
Mm-hmm.
Our species, we're mammals, so we have that reflex. I'm not bothered by pacifiers. I've never been. My kids use pacifiers. But a lot of kids are not taking pacifiers because their nose is not working. And we have evidence of anthropological pacifiers. We don't have anthropological spoons. I'm more concerned with feeding kids with a spoon. But the pacifier has been around. The word pacifier it's a good word because when we're sucking, we are liberating a lot of serotonin and different hormones, and in the back of the palate we have receptors. Dr. Restrepo, our pediatric dentist in Colombia, she's done a lot of work on that. There's receptors that release, I don't think it's dopamine, I think it's serotonin, but she talks about the whole hormone stimulation of that non-nutritive sucking reflex. So we want to have tools and use them the way they're supposed to and the timing that they're supposed to be used. So the sucking reflex with a nipple or a pacifier should be before the teeth come in. Once we get to closer to a year and the teeth start erupting, we should fade out of the pacifier. That doesn't mean that we fade out of the sucking reflex.
Right.
We should have that reflex even as adults. So what do? We created a transitional pacifier that has a shield that goes between the lips and the teeth. And it's in order to activate this shield, the tongue has to be sucked to the roof of the mouth.
That's great.
And that's how we use the word stewards of that sucking reflex that needs to evolve from being a reflex that is designed to be sucking on a nipple to a reflex that's designed to rest with all our tissues away from our airway with that slight negative suction in the roof of the mouth or...
That's great. And so are these for use after teeth or before teeth?
Well, we have the series of pacifiers. Ideally, we shouldn't need to.
Right.
But if we haven't transitioned to that resting reflex with the sucking of the tongue in the roof of the mouth, then we can use one of our pacifiers. We have a 0 to 6 months, which is a regular pacifier, but it has feedback mechanism. So you know if the baby is sucking well or not. So we are using that with the sick babies that are in hospital or they use a trach to breathe or to be fed. And once they transition to swallowing properly, then we use our pacifiers to kind of foster and store that reflex throughout life. Even adults, we have the up locker.
Yeah.
And I brought you one to test because one of the ways we use it is for patients post-surgery. Just like when you have your knee worked on, you have your rehab. And before you even go in the OR, they give you the card for the 3 or 4 guys. You can go for the rehab.
Yep.
So what do we do for nasal surgery, for maxillofacial surgery? I'm sure you do. You have because I've gone through it. You have your exercises to open up and to swallow. But the pacifier that we use is very helpful after surgery to start using that real estate and understand how to use that bigger palate and to retain or even maximize what you're doing. Because we know there's a lot of relapse in orthodontics for sure. And it used to be in oral surgery, we had a lot of relapse. Yeah,
used to. For different reasons. Obviously, technology and the plates and protocols are better. But even with execution, if we're not paying attention to the muscle function, there's going to be changes in the bite that are adverse and then changes in the face. So we strongly believe in myofunctional therapy for all our patients. I'm really curious to see your input and what other things patients can use. I'm really interested in continuing to make this surgery better. We think about that all the time, and the recovery better. So I know there's a lot of work on the recovery side that excites me, especially if you think about biohacking. And this seems like one of those things. So I'm interested to get into that. What do you think the problem with traditional orthodontics are? I have a quote from the book. It says, as in so many professions, dental schools were pumping out students whose practices were by the book, but not necessarily best for patients. I still find that not much has changed since I left school about 20 years ago from dental school and training, 13 years ago. What is that? Why do you think that things are not changing?
Well, medicine and healthcare has always utilized as a standard of care the idea that it's what the most of these practitioners are doing, and that's the way we learn to stay safe.
Yeah.
So if you are practicing the standard of care, that doesn't mean that it's the best.
Right.
Standard is never the best, right?
Right, that's true.
So when we're saying that that's what we're doing what most people are doing. So we're not sticking our head out. We're staying where everybody is.
Yeah, exactly what you said about parenting. It's not making a mistake. It's just looking to the left and right and doing the same thing.
Exactly. So we need people like you who are a trailblazer, and you're starting to do the surgery in a completely different way.
Right.
I graduated 1989, and I loved surgery, but it was really, we used to say carniceria. It was just,
I know what that means.
Yeah. It was like bleeding and cutting. And, I used to come in and say, okay, let me do the separation of the maxilla and get the chisel there.
Yeah.
And it's definitely, something that has changed because technology now allows us to do much different things. But there's still surgeons doing that because it worked for them.
Correct.
And then they're done with the surgery, they close the patient, they send them away, and they never see the patient again.
Yeah.
And that happens to orthodontics where we do the same thing.
Yeah.
They want this one tooth in the front is crooked, so we put it straight. They love it, they smile all day long. We tell them to go where they retain it forever, and we never see them again.
Yeah.
So this is kind of something that the patient really needs to take on. This is why I love Peter Attia's concept of reverse engineering your health, because that means just going in the future and say, what do you want your future to be?
Right.
If you want to be, living in the third floor and going up and down the stairs, you got to do it now. You can't wait until you're old to do that.
Yeah.
So our professions need to be guided now by the general public.
Yes.
It's unfortunate.
Yeah.
We could do better.
I think
that is
there's
the
a
path.
lot of truth to that too. And what a time to do it because, days like this, we can sit here and have these conversations and the general public has access to experts like yourself and information in ways that was never true before. And I do think that in the last year, I've seen more adoption and transformation and subscription to everything that you're writing in that book. Exponentially more adoption than I had in the last 10 years. So it is an exciting time. GoPex. What is GoPex?
So GoPex was born from me trying to help my son when he was 10 or 11 years old.
Yeah.
And Dr. Simon Wong from Australia, he was showing some amazing cases online. And I said, okay, I need this. And he says, well, these cases are using my exercise program.
Yeah.
I said,
before you continue, on that point, you wrote this and I quoted it. She could not do to her own children the same way she was doing to other patients.
Yeah, I couldn't. The standard of care wasn't good enough for my beautiful, perfect child, right?
Yes.
He had to have beautiful jaws, and he's. That's why I retired in 2014. I sold my practice after 25 years.
Yeah.
Because I just couldn't do it anymore. I couldn't just slap braces and make money out of my patients.
Yeah.
And if it wasn't for my son, I'd still be doing that today.
Yeah.
And I wouldn't be in this crazy place that I'm now. But definitely, GoPex was this good oral exercise program that Dr. Simon was doing. He wasn't calling it that, but I said we had to take this to the world.
Right.
So I went to Australia and wrote the book.
I love that.
And then I came back, and then I wrote the other book.
Yep.
And it's interesting that it really, once the book is written, it's not exactly obsolete, but it really tells you a lot more of what you don't know. And the patients take my book, Breathe 4.0, and they look at it, it's 500 pages long, and they say, who's going to read this, a patient or a doctor? And my patients, a lot of patients tell me they take it under their arm to their doctor.
That's great.
And say, well, I want you to look at this chapter on snoring. We have 3 chapters, snoring. We have snoring, mandibular advancement device, because we have our own, and CPAP. So those 3 chapters, I think they're the most looked at. We also have a chapter on sports and how to make more efficient your breathing to recover better.
That's great.
So the athletes take this book under their arm, and they go to ask for the professional.
Yeah.
And I'm not a big online presence. I'm not as smart as you are in doing these information
I think
stuff.
you'd be very good at it.
But I think once they have it in the book, they can go back and say, okay, this makes sense.
Yep.
And then they can complement what's online, because there's a lot of mix. It's a mixed batch.
Yeah.
Some great things, and most of the people are telling people what they want to hear.
Correct.
Like, don't have surgery, and don't do this. You can just do this without, having to risk going to surgery. So they need to have good information so that then they can learn online and see what works for them.
Yeah. When I remember learning about orthognathics, dental characteristics, and a lot of the emphasis was that genetics played such a huge role in retrognathia, all these things. I think there's a misconception there. I want to hear your thoughts on that. Is it genetics, or is it change in culture? Obviously,
it's not one or the other. Like Paul uses the example of a rectangle.
Yeah.
It's not, the surface is not just either the height or the width. It's both. But one of them is a lot more relevant.
Right.
And I think the environment is 80 or 90% more of our jaw's development. Because if you look at ancient remains, you can see that they were all pretty much the same.
Right.
And they all had 32 teeth. No, I've talked to paleontologists that have held more dry skulls that are over 100 years old than anybody else. And they all tell me it's very, very rare to have a pre-industrial skull. And from the Industrial Revolution to here, in evolutionary time is nothing.
Right.
It's very, very little.
Right. The genetic code has not changed as much as the faces have changed.
Although we do have epigenetics, and writing the new book, the Nose book, we are just starting for the first time to see evolutionary changes that are happening in a short period of time because of epigenetics and how we've tweaked that environment so quickly. Just from the Industrial Revolution to now, the air has so many smaller, and it's coated with more particles. It's very important people to know that stuffy noses are not necessarily allergy. They're just overwhelming of the number of particles. We use the example of me. I'm from Mexico.
Right.
So when my mom's making chiles and she's toasting them, or I go into the room that's full of chiles, my nose starts running and itching. Doesn't mean I'm allergic to chiles. I can eat as many as I want. But when there's too many, my body will react. So it's more of an overwhelming of what we have that's new in our air.
Yeah, that's interesting. Can braces make things worse?
Absolutely. Absolutely. I feel very, very fortunate to have grown up in a different era and not with a lot of money. Otherwise, I would have had braces, and I would have had my class 2 pushed back.
Yeah.
And I was able to have my mandibular advancement over a centimeter in my 50s. And I didn't have to deal with the side effects. And I have a lot of patients, a lot of consultations I do with patients that have had the wrong thing done just to get that quick fix.
Yeah.
So I love my profession.
Yes,
I am an orthodontist, first of all. That's what I am.
Right.
I love it. I've wanted to be an orthodontist since I was a kid. And I was assisting to my neighbor who was an orthodontist. And I would go in the afternoon after school to help him. And I said, this is where I want to be.
Right.
Because he was the only one in the practice of, they were all dentists, but he was the only one that didn't have blood in his trash can. And this is a time where we're not sterilizing. We just clean the pliers with alcohol and put them back. And his place was always clean, where the surgeon was always dirty, full of blood. That's not for me.
Yeah.
So I love being an orthodontist. I think it's the best profession there is.
Yeah.
But we really do for a big check and reform, and we have to evolve to this new. And I'm looking up to you to do it. Because
we're trying.
Yeah, you got to teach my profession how to prepare the cases for you.
Yeah.
Because I know from preparing cases for my surgeon in Spain that what I was doing is not useful for you guys.
Right, and it's so different than what I learned, and what the orthodontists learned how to set up cases. The philosophy is completely different. But we
are afraid of you guys, though.
Yeah.
Traditionally, we are very afraid of the oral surgeon.
Yeah, I don't know if anyone's afraid of me.
You need to come down and speak our language and tell us it's fine. We'll make it work. And
correct.
We always see the surgeon as, you were the number one student in the dental class, right? So you were a step ahead of everyone. And we were number two, because number two was always the orthodontist, right?
Yeah.
And the rest of our colleagues were afraid of us.
Right.
But we really are intimidated by the surgeons. But I'm here learning what you're doing, and I think you should be out there teaching orthodontists how to set up these cases and how to present them to the patient.
Yeah, I agree. And not to be afraid of the surgeons or the surgery itself, because it's so different. But not everyone's exposed to that or has met that experience. But I agree. I think our goal is to set the message out there. This is such a powerful biohacking tool. The question too, for the pediatric dentists, we have tremendous pediatric dentists that are disruptors and forward thinkers like you are, and what they're able to do for children and expand their jaws so quickly at an early age is really tremendous. And that's very exciting for me too, with young children, but also for healthcare and society in general. If we were to, correct this jaw epidemic early, what would that mean for medicine altogether? What would that look like?
That's a great question. I don't think we would get everybody perfect, but we could have a median of people that are not struggling with a lot of the diseases of, I don't want to call them civilization diseases, but they're diseases that are of continually taxing our body. So if you're not sleeping well, if you're not breathing well, and you're struggling, then you're going to put resources somewhere else. And we're doing a lot of work right now with our pacifiers, finding out that kids that get to sleep 95% with 95% effortless nasal breathing, they measure deep sleep in higher volumes. So we have kids, and anybody that can breathe through their nose is going to have more deep sleep. And deep sleep translates directly into cleaning your brain, into the organizing memories, organizing, integrating emotions. So we have kids that are number one in school, fine, but they can't keep their things organized, or they're throwing tantrums all the time, and that is a very specific, very clear sign of, something's not going on at night, and it can be traced down to the nose. So if we get kids to have all their teeth, that's the first sign. If all the teeth fit, if young kids, 4 or 5 years old, have diastemas and they have big, wide jaws, that means their nose is working well. So they go hand in hand. So if we could get all the kids to breathe better, we would have a lot less of these taxing diseases, I call them.
Yeah, I think we looked it up. 3.5 million children are on ADHD medicine. How many kids have behavioral problems, throw tantrums, or not succeeding in school, or parents are having a hard time in the house? How much of this is just something as simple as breathing?
Big part of it.
Yeah. It's crazy to think. One of the things you hit home, I feel like when I read your text, You think along very similar to the way I try to think of things, and some of the phrases you put there, I feel like I've said these things. It's pretty interesting. And one of the ones that you really hit home is, what we accept as normal is not healthy, not necessarily healthy. Can premolar extraction make the mouth smaller?
Of course.
Yeah. Why is there so much denial in the community?
That's what we were talking about, the standard of care. That's,
right.
That's what has been done.
Yep.
And I think in the U.S., at least in California, there's very few doctors that are doing it. And you have to really be older. But we had treatments that were barbaric.
Yeah.
Like the what you used to call it, where you took the bud out before they even erupted. I forget the name of that. But I learned it in school. So if you see that the patient was going to be crowded at 7 or 8 years old, you would ask the surgeon to remove the premolars before they even develop.
Wow, that I've never been asked.
Yeah, it was, what was it called? I have to look it up. But yeah, we're moving away from premolar extraction.
That's good.
But definitely, that the bone follows a tooth.
Right.
Any dentist knows that if you lost a tooth, you're going to lose all your bone.
Right.
So if you take out the premolars, you're going to have smaller jaws.
Yeah. I agree. I think it's obvious. I think it's interesting because I ask this question a lot, and there's a lot of dancing around that answer. I'm glad that you can acknowledge what seems to be truth. And, when you accept the truth, that's when we can really make changes.
Well, the question maybe it's framed differently. Do the extraction of the premolars make the mouth smaller, or a smaller mouth doesn't have room to fit them, so they take them out?
Right.
So I think it's a combination.
For sure.
It's not that it makes it small, but then you don't have the ability to expand and get all those teeth in. Yeah. I wish I had time to show you some of my beautifully expanded cases, because I have a collection that goes on and on with,
I would love to see. We're going to have to find time.
Yeah. I'll just email you some stuff.
Yeah, that'd be great.
I've been a fan of expansion from day one.
I love that. Yeah, you're such a forward thinker. It's amazing talking to you. I love the way you address all the questions, think about stuff. I can tell your passion for it, and that you're going to continue to change the way everybody's doing things. So it's really exciting.
Well, thanks to you guys.
Thank you. And I'm excited. Hopefully we can get you into the operating room tomorrow. I think it'll be fun to share and hear your thoughts about what you're seeing, and see what we can learn from this discipline approach. I like that. Well,
I got you a book, so you'll have next time I'll come, you'll have an exam.
Yeah, that'll be great. I wish we can do this for another hour, and maybe I'll have to find a way to get you back. But for now, I ask this question to everybody. Who's the best basketball player of all time?
Was the UNC guy?
Michael Jordan?
Michael Jordan.
There you go.
I obviously not a basketball fan.
Yeah, but
my daughter goes to UNC.
But you somehow seem to know the right answer.
Yeah, he's the greatest.
Yeah.
I'm from Mexico. Yeah. And I'm 1.5 meters tall, so that's not my area of expertise.
Yeah, you'll probably tell me a lot of soccer players, I'm sure.
Oh, yeah.
Awesome. Thank you very much. Whoever has questions in the leave comments below. Share this information. I think for Sandra, Dr. Kahn here, and for me, I think we do have a joint, desire to spread this message. And I hope that everybody gets healthier, and we continue to change the way things are.
And I definitely want to use your term, minimally invasive maxillomandibular advancement, because that hasn't been used, and
correct.
I think you're there.
Yeah, definitely. Yeah, there's so much technology where things are so much better and less traumatic, less invasive, and hopefully we can. I know we can continue to think about ways to do things in that direction. So it is exciting. Yeah. So thank you very much.